Good afternoon, and welcome to the inaugural program presented by the Thomas E. Starzl Transplantation Institute's virtual classroom. My name is Sandy Chico. I'm the Director of Development for the Starzl Institute at UPMC and the University of Pittsburgh. The last few months have been consumed by talk about COVID-19, its origins, its symptoms, and how we can stop its spread. For transplant patients, this virus presents additional concerns that can be particularly frightening. So today we've brought together some of our colleagues from the Starzl Transplant Institute to answer questions many of you may have and to share the unique challenges of running a transplant program in the midst of a pandemic. Each of our three experts will share a short presentation followed by a question and answer session. First will be Dr. Mindi Styn, Director for Research Administration and Academic Affairs. Dr. Styn is responsible for the day-to-day operations of the Starzl Transplant Institute's research efforts and we'll discuss the epidemiology of COVID-19. Next up will be Dr. Fadi Lakkis, who is the Frank and Athena Sarris Chair in Transplantation Biology and is the Scientific Director of the Starzl Transplant Institute. Dr. Lakkis will share the science of COVID-19. Finally, we will have a presentation by Dr. Abhinav Humar, who is the Chief Department of Abdominal Transplantation Surgery and the Clinical Director for the Starzl Transplant Institute. He'll talk about running a transplant program during a pandemic. With that in mind, let us turn it over to Dr. Mindi Styn to discuss the epidemiology of this virus. Mindi?
Thanks, Sandy. And as Sandy said, I'm going to talk about the epidemiology of COVID-19 and what we know so far. And I want you all to kind of come away with this talk with a better understanding of some of the terminology and some of the numbers when you're watching news reports about COVID-19. So what are coronaviruses? And I know sometimes this is referred to as the coronavirus pandemic. But really, this is just one of several coronaviruses that are found in humans. And there's also a group of viruses that are found in certain types of animals. The common human coronaviruses typically cause seasonal viral infections like the common cold. So they're not that serious. And typically the coronaviruses that infect humans or infect animals don't infect humans. And just a kind of fun fact here, the reason they're called coronaviruses is because they look like they're wearing a crown in the electron micrographs. So it has nothing to do with beer. So as I said, most of the human coronaviruses do not cause serious infections, but we have had 3 in the past 20 years that have emerged, that have come over from animals into humans, called novel human coronaviruses. The first was in 2002 when we had the original SARS epidemic. And this is severe acute respiratory syndrome. SARS was identified in 2002. It kind of wreaked havoc for about 6 months in 2003, and then it went away. It was adequately contained so that people who had it weren't infecting others, and we don't see SARS, the original SARS virus anymore. In 2012, the MERS virus appeared. It's the Middle East Respiratory Syndrome, and we still do have some cases of MERS. And then in 2019, we started to see cases of pneumonia that were then traced back to a new kind of SARS virus, similar to the one from 2002, but genetically different enough that it got the name SARS-CoV-2, and it causes COVID-19. And so, as I said, typically, these coronaviruses that infect animals don't come into humans. We believe that all 3 of the novel coronaviruses have come from bats originally, and then they went into other animals, such as in the case of The original SARS, it went from the civet to humans. In the case of MERS, it goes through camels to humans. And we don't know yet for SARS-2 exactly what the intermediate animal was. There's a possibility that it went directly from bats to humans, but that's not the predominant thinking. It's possible it went to an animal called a pangolin first, and then went to humans. And there's also the possibility that there are different pathways that the same virus went through before it came to infect humans. And so going back to this idea of we don't really know where it came from, I think that's a common theme over the past few months. And it has led a lot of people to just kind of throw up their hands and say, does anyone know anything about this virus? We hear conflicting reports. We hear things on the media that are these inflated numbers, are they deflated numbers? And it makes us all frustrated, professionals and people who are just trying to figure out what to do for their families. And why is there so much confusion? So I want you to keep in mind this timeline that we had a few cases that were diagnosed in December in China of this new pneumonia that was different from what we've seen in other patients, but similar to each other. And so by January 4th, this was reported to the World Health Organization that there was this cluster of about 35 to 40 pneumonia cases in China. They hadn't yet identified the cause of these or the seriousness of it. By January 7th, laboratory studies were done that showed that this was a novel coronavirus. So it wasn't an influenza, it was a coronavirus. By January 19th, we had our first case in the United States. By the 24th, the first cases were confirmed in Europe. And by the 30th, so less than a month after this report of a cluster of pneumonia cases, the World Health Organization declared it a public health emergency of international concern. About a month later, we had our first death in the United States, but we had only had experience with about 50 cases here. And so again, thinking of this, we had about 6 weeks of watching this disease in very few patients. And now we have to be putting out guidance to the public for how to handle this and what to expect. And so that means that we had to rely not on direct data from this virus, but kind of extrapolating what we know from other viruses and taking educated guesses as to whether it would behave like things we have seen before. And then on March 11th, it was declared a pandemic. By that point, it had hit every continent except Antarctica. But we still had just over 1,000 cases in the United States, which really isn't a lot for us to go on. It doesn't provide us with a lot of data. And then this graph just kind of shows the point that we had to make a lot of decisions and put out a lot of information with very little data and a situation that was changing rapidly over just a few months. So I just want to touch briefly on the problem with misinformation in the coronavirus. I would encourage you to go to this Smithsonian Magazine article about how to avoid misinformation, because we know from studies that have been done on information spread that misinformation spreads much more rapidly than accurate information. And it can be easy to get hooked into some of these inaccurate reports. So I kind of boiled down that into 4 questions that you should ask yourself when you're looking at information about the coronavirus. So the first is it boring? Scientists don't typically write very exciting reports. Typically, people who want to hook you in are the ones who are trying to get you fired up. Is it from a reputable source? So is it from a .gov website or a .edu website? Is it opinion? An expert opinion is okay, but it's good to know whether what you're reading is someone's personal opinion or whether it's really based on data and fact. You should always be aware of bias in your source and try to confirm things with other sources, especially going back to these reliable sources. And finally, especially important in the case of this pandemic, is whether the information is current. Information from March may not be accurate today, and a case in point would be the issue of masking, which has caused a lot of confusion because at the end of February, there was guidance that we should not all be wearing masks. And by the beginning of April, we were all told that we should be wearing masks. And there's still some of those The Surgeon General tweet about not wearing a mask that circulates around, and people saying that there's conflicting information. And really, it's just a matter of it being old information. And also, before I start throwing numbers at you, I want to go over how we can make sense of some of these numbers. And so I want to give you two examples that you can look at to think of how infection rate and case fatality rate affect the bottom line of how many people are going to die from a disease. So in this case, we have a population of 50 people. We have an infection rate of 20%, a case fatality rate that is really high. About half of the people who are infected will die from this disease. And so our total mortality in the population is 10, and basically we have 5 people who have died out of 50. For our second example, a lot of more people are getting infected. We have an infection rate of 50%. The case fatality rate is lower, it's only 20% as opposed to the 50% we had before, but the end result is still the same. And so when there were a lot of questions about testing and whether we were getting enough cases, the case fatality rate numbers that were being presented to us were varied widely. But really, if you just look at the mortality caused by this disease, you can see the severity of it. And also, I want to talk a little bit about population adjustment, because again, sometimes news reports will show just total cases of COVID-19 or total deaths, and that can be skewed based on the number of people in the population. Obviously, we would expect a country as big as the United States to have more cases than a smaller country like Peru. So when we adjust for the population, we can see our numbers are still quite high, but they're not enormous compared to the other countries like it looks when we do total cases. So thinking of those numbers about the number of cases and the case fatality rate, we can compare the 3 novel coronaviruses. So we have the original SARS that was short-lived. It had a much higher case fatality rate than what SARS-2 does, but because it infected so few people, we had far fewer deaths. The same with MERS, it has a really high case fatality rate, but it really doesn't spread that easily. And then in the case of SARS, we have a lot of people who have been infected, a lower case fatality rate, but it still has led to a lot of deaths. So let's just talk a little bit about the terminology of why those other 2 SARS weren't considered pandemics, but this SARS became, or the other 2 coronaviruses did not become pandemics, but this one was declared a pandemic. So we start with an outbreak, which is a sudden increase in diseases in a very particular time and place. So this would be in Wuhan, China, where the first few cases were discovered. And then we have an epidemic where the disease spreads, but it stays pretty regional. And then we have a pandemic, which is the worldwide spread of the new disease. And so if we take real images of the spread of COVID-19 across the globe, we can see this definitely is a pandemic. And this happened very quickly, as I said. By the beginning of March, we had cases on every continent except Antarctica. And we can see the spread in the United States. Again, this is not adjusted for population, so some of these less populated states appear to have far fewer cases, but maybe if we adjusted for the number of people in those states, it would look a little different. So how does it spread? I've said it spreads quite easily. It spreads easier than the flu, but not as easily as the measles. And it's really the big culprit is these droplets that come out of our mouth and come out of our nose when we're breathing, talking, singing, sneezing. And there was research done in the early 20th century that kind of showed how far these droplets go. And we have some larger droplets that don't go quite as far and smaller ones that go out about 6 feet. And so that's where the 6 feet recommendation comes from. Of course, if this man was wearing a mask, it would not go quite as far. And I know there has been concern about whether we need to be wiping down packages or be worried about our mail. And at this point in the pandemic, it seems that this person-to-person contact is the primary mode of spread. And keep in mind too that people can be pre-symptomatic for approximately 2 to 14 days before they actually show symptoms and would go get tested for COVID-19. And so that's why it's important for even asymptomatic people to wear a mask. And I think we all have seen different versions of this, of how to prevent COVID-19. Washing your hands often is always a good idea. I don't know that I would sanitize constantly, but I would be aware of surfaces that need to be sanitized if you've been out, or if someone has been in your office, or if you're touching things that other people will touch. We have that recommendation of 6 feet of distance, avoiding crowds. As always, we would want to cover our coughs and sneezes. Staying at home is one where people need to balance the risk and benefits. And then, of course, wearing a face mask, which is a very simple way that is being shown more and more to stop the spread of the disease. So who gets COVID-19? Pretty much everyone across the age spectrum gets COVID-19. There had been reports that maybe children were protected from it, but they do actually get COVID-19. They don't get it at the rate that we would expect. If there was no difference by age, we would expect this bar to be similar to this bar, which shows the distribution of age in the population. And we do see a little bit of an elevation in the 75 years and older group. But really, this is kind of a significant decrease in what we would expect. And part of that is probably because of less testing of children, because their symptoms are less severe. And part of it is actually probably just a true fact that they don't get the virus. They're not as susceptible to the virus as adults are. There was a study done in Israel in April that looked at families that were quarantined together, and adults in the family were much more likely to get the virus than children. So children don't seem to get it, and they don't seem to spread it as much as adults do. And that's not really a well understood phenomenon. So how sick could I get? That's another question that a lot of people have. Like, how serious is this? And these are the common COVID-19 symptoms. If you want to go to the CDC website, you can see some of the less common symptoms, some of the symptoms that are kind of unique to COVID-19. So they're not necessarily common, but there's something that would raise a red flag about COVID if you presented with them, such as the COVID toes that you may have seen in children. But the challenge with this is that we don't have any really good data about how sick people get, but not to the point of being hospitalized. So we have estimates that about 40 to 80% of people who are infected are actually asymptomatic and don't show disease. This is based on small population studies and some contact tracing, which is why it's not a real precise number. There's a pretty wide estimate there. And then we have numbers on hospitalization and we have numbers on death. But what we don't really know is, in this range, how many people get so sick that they can't function? How many people just get the sniffles and go on with their day? And that's something that's going to be important to understand over the course of the next few months as we decide on reopening and really trying to figure out how severe the disease is in younger populations. So there are certain conditions that have been shown to make COVID-19 worse. And just recently, on June 25th, solid organ transplant was added to the list of risk factors that can increase your risk of severe illness from COVID-19. There was a lot of concern when people were looking at the possibility of this pandemic reaching the United States, because we have such high rates of obesity and type 2 diabetes, and those also increase the risk of severe illness. There are some other conditions that possibly make COVID-19 worse, but the evidence is a little bit weaker. Type 1 diabetes, immunocompromised state from other types of transplants, liver disease. But age is really the big risk factor for disease severity. So as you can see here, and this is adjusted for the population. And so we would expect the the line for kids to be low, but we would expect all of the other lines to be together if there was no effective age. But as you can see, your risk of being hospitalized due to COVID-19 increases with age and really jumps in the 65 and older crowd. And also the risk of death increases with age. Again, this is adjusted for the population, so we would expect these to be somewhat similar, but they definitely are not. And this is specific to New York, but we've seen similar patterns across the United States and across the world. So how does this all end? I know there's been a lot of buzz about herd immunity. I've heard the term tossed around incorrectly sometimes. So herd immunity is when about 50 to 90% of the population develops immunity to a disease, maybe not 100% immunity, but they have antibodies that make it harder for them to get a disease. So our best bet for this to end is if we can get an effective vaccine and induce herd immunity that way. A less desirable option would be herd immunity through infection, because we'll have a lot of death, we'll have a lot of morbidity, so a lot of illness if we have to go this route. So it's not really the desired route. Until we get a vaccine, we want to keep the numbers low so that we can keep doing research on better treatment, and so that we can also figure out better detection and prevention. So if we can test more people and do some contact tracing, we may be able to keep those numbers down. And so I'm going to hand it over to Dr. Lakkis. He's going to talk a little bit about vaccines and treatment. So this is a good segue into his talk. So Dr. Lakkis is the Frank and Athena Sarris Chair in Transplantation Biology. He's also the scientific director of the Starzl Transplant Institute. And he's going to talk to you now about the science of COVID-19.
Thank you very much, Mindi, for the introduction. What I would like to speak to you today about is COVID-19 and your immune system, or as Mindi said, some of the science behind COVID-19 and why the immune system is important for protecting us against this type of infection. And this is very relevant to some of you who may be listening who are transplant recipients. First, a quick reminder of COVID-19 infection. And the first reminder is that approximately 80% of COVID infection is indeed mild. And as Dr. Styn said in the previous lecture, these numbers are not necessarily very accurate, but they give us some kind of idea. And it's quite possible that about a third of these patients, or even more, could be without symptoms. However, in about 15% of individuals who contract COVID, the infection can become severe, which means that they develop a pneumonia. And in about 5%, the pneumonia can be sufficiently critical, which means that their blood oxygen drops down and multiple organs can be affected. These are normally patients who are hospitalized, and some of them, perhaps about a third again, may need critical care in an ICU. So why is it that this infection is worse than other viruses that cause the common cold or the flu? And really, the main reason is that COVID is an invader. It invades our bodies and can cause quite a bit of damage. And the first site of invasion is the lung, and thus the pneumonia being the most dreaded complication of COVID infection. So in this picture, you can see that the air sacs of the lung have been infected. The cells that line them have been infected. This causes the cells to produce a lot of mucus. And it also causes the immune system to send its warriors, the cells, into the site of infection. And these are pus cells that can then cause pneumonia. Another striking feature of COVID, which makes it different from other respiratory viruses, is that it appears to infect the blood vessels, the capillaries, the small blood vessels around the air sacs. And when it does that, it can form a blood clot. And these blood clots can make the pneumonia worse. They can lower the oxygen in the blood because not enough blood reaches the lung to become oxygenated. Now, if the virus were to spread further in the body, and it does, it can affect many other organs shown here on the right. Some of the symptoms and signs that emerge from the virus spreading in the body are due to the virus itself infecting these organs, or perhaps due to the consequences of the severe pneumonia, the low oxygen, and maybe the drop in blood pressure in someone who is critically ill. So for example, the virus can cause inflammation in the brain. This is referred to as encephalitis, but it can also cause other mental symptoms such as delirium, confusion, fatigue, as well as headaches. And headaches can occur in up to 50% of individuals infected with COVID. It can cause a red eye or conjunctivitis. Although runny noses do not seem to be commonly seen in COVID, some patients can lose their sense of smell, and you've read about that in the media, I'm sure. The liver can be affected. That's normally observed as abnormal blood test. It's not clear whether the virus itself can infect the liver, or it could be a side effect of many of the medications that someone infected with COVID and severely ill may be taking at the time. Kidney damage has been observed, and some scientists think that the virus can directly infect the kidney and cause damage there, or the kidneys can be damaged due to the severe pneumonia and a patient whose blood pressure has dropped, who's in the intensive care unit, and whose oxygen may be low as well. And finally, when COVID infects the intestines, it can cause diarrhea. So as you've heard before, not everyone gets severe disease, and there are risk factors for severe infection. So I'll remind you of them very quickly. And these include underlying conditions where the heart or the vessels or cardiovascular disease is involved, diabetes, high blood sugar, high blood pressure, chronic liver disease to some extent, certain types of cancer, such as cancers of the blood, the lungs, and advanced metastatic cancer, chronic kidney disease, obesity, and older age. Perhaps one thing that ties all these predisposing conditions together is an immune system that is slightly weakened or sometimes severely weakened. And in fact, this is very relevant to transplant recipients whose immune systems are weakened by the fact that they take medications that prevent rejection. So this would be my introduction to why the immune system is important to study in COVID disease and why it's important to understand it. So let me introduce you a little bit to the immune system before I get into why it's important in COVID infection. The immune system is this amazing set of cells and molecules and proteins in our bodies that protect us against foreign invader, specifically infections, and most importantly, viruses. But this immune system is the same system that also recognizes a transplanted organ such as a kidney, a heart, a liver, a lung as foreign and attempts to reject it as well. It's the same thing that protects us, can also reject a transplanted organ. And therefore, transplant patients are obligated to take immunosuppressive medications, medications that weaken the immune system for life to prevent rejection of the organ. But these medications also prevent rejection of a foreign invader such as a virus. So the protection against infection is diminished. And that's why it's so important for transplant recipients to be aware of COVID, their immune systems, and why it's important to take preventative measures to avoid infection. So how is it then that the immune system fights a virus like COVID? And what does that teach us about what happens during such an infection? And what can we do to provide people with better protection? So the immune system, it turns out, is quite amazing, but it's even more amazing because it's really two systems in our bodies. The first one is known as the innate immune system. It's a more primitive system that can respond very quickly to a virus. So when it detects a virus, it can very, very rapidly emit molecules and proteins that try to neutralize the virus or to kill it, as well as cells that try to eat it. So this is like a bag of pus. For example, if you were to get a bacterial infection, this is the immediate response of the body to the virus or to any other infection. The problem is that even though the innate system is very rapid in responding, it's not very effective. It can hold things off for a few days, but not completely. And therefore, its other and more important function is that it alerts the adaptive system, which is a more sophisticated system, to recognize the virus and to attack it. And the reason it's more sophisticated is that it's made out of cells known as T cells and B cells or lymphocytes. They are white blood cells that can either, such as the T cell, directly kill the virus, or such as the B cell, they can make antibodies, molecules that can neutralize the virus and prevent it from infecting other cells and even eliminate it from the body. So the adaptive system is really the more sophisticated system, and the innate system, you can imagine it as the doorbell that wakes up the adaptive system, and the two together can do their best to fight off the virus. However, there's something interesting in COVID that was quickly observed in patients, is that the immune system in infection, such as COVID, is a double-edged sword. On one edge of the sword, it's controlling the infection by providing protection and fighting molecules and cells against the virus. On the other side, these same cells and molecules can cause inflammation, and inflammation itself can be harmful to the body. So in the process of fighting the infection, the immune system can be damaging the tissue. And thus, many of you may have heard on the news that some patients were treated with dexamethasone, which is a corticosteroid that suppresses inflammation. It is similar to prednisone and other same class medications that are used in transplantation to prevent rejection. And in one study in the United Kingdom, it was found that the use of dexamethasone in patients with severe COVID who are in the hospital, mortality is reduced by approximately a third or 30% because of the reduction in inflammation. So the immune system is very helpful, but it's a double-edged sword, and sometimes we have to control it from overreacting to the virus to prevent tissue damage. But the main reason that the immune system is so key to a virus, or key to us to protect us from viruses, is vaccination. So as Dr. Styn has told you, the virus is new to humans. So we are naive. We have never seen it before, which means that even though our immune systems have these sophisticated cells, they are still naive or uneducated, and they're rather sluggish in reacting to the virus, and there are too few of them that can sense the virus. However, if you were to vaccinate someone, what you are doing is generating memory cells, generating more of these T cells and B cells, and they become more potent and more long-lived, which means that hopefully they'll last a long time and provide protection over many months and hopefully over many years against the virus. An important cell that once it becomes memory is the B cell, because it can produce antibodies. And the antibodies that are normally referred to that are important for protection against infection are IgA and IgG. So a good vaccine should make both. The reason is that IgA is the one that protects us from infection in the first place. IgA is produced by the cells that line the nasal passages and the airways, as well as the intestinal tract. So any IgA that can neutralize the virus will prevent it from entering the body in the first place, because COVID is a respiratory virus. That's how it enters the body, through the nose and through the airways. And if we were making enough IgA at these locations, then the virus is stopped in its tracks, and that would be really ideal. The second antibody that is important is IgG. IgG circulates in the blood and protects us from invasion by the virus, or prevents the virus from invading other organs in our body. So circulating or bloodstream IgG is also important. So I'd like to repeat that an optimal vaccine would be one that would give us protection in the air passages as well as in the bloodstream by making both IgA and IgG. These antibodies are also important because scientists can develop assays that can detect them. Therefore, we can tell who has been infected with the virus and who has become immune to it because they have sufficient titers of these antibodies. So as I mentioned, Vaccines are not there yet, or as Mindi mentioned, but many are currently in different stages of development. Some of them are attenuated virus, which means a virus that is still alive but has been weakened, so it doesn't cause any serious infection, but instead it can activate the immune system. Others are referred to as recombinant vaccines, which means that there are proteins derived from the virus that are produced in the laboratory and then injected into humans. And there are even vaccines that are made of the genetic material of the virus that can be injected into the human, and then they can activate the immune system to make antibodies against the virus. In some cases, clinical trials are currently ongoing. They have already begun in the UK, in the US, as well as in China. But until we have vaccines, the population is still naive to the virus and highly susceptible to infection. Therefore, one would, of course, ask, is there a treatment if I were to get infected with COVID? I would focus on the transplant recipient who's taking immunosuppression. And the most obvious strategy that a physician and a patient would take is to reduce the amount of immunosuppression they're taking, which means reducing the dose or even removing one or more of the immunosuppressive agents that are weakening the immune system and are being used to prevent rejection. The second approach is to use medications that can actually kill the virus. And by killing the virus, I mean that it stops it from dividing and from infecting other cells. And one medicine that you may have heard about in the media is remdesivir, which has to be given IV or intravenously by injection. And remdesivir has been shown to provide about a third protection in patients who are already in the hospital, which means it can protect about a third of the patients from dying, from mortality, and it can shorten the duration of hospitalization, the length of stay in the hospital by about a third. A third medication or third approach is corticosteroids or dexamethasone, which I mentioned before, which is intended to reduce the inflammation so that the immune system doesn't damage the body it's trying to protect. And that, again, the study showed that the protection is about a third, which is very good, but of course not optimal, and more needs to be done. And finally, there are attempts to use immune serum, which means serum from people who have already been infected with COVID virus, who have recovered, and therefore they have antibodies that can neutralize the virus. And if one were to transfer the serum to a patient who is recently infected or who's very sick, the hope is that the antibodies present in the serum can then prevent the virus from spreading further in the body. There are even companies now that are producing antibodies in animals and in the lab so that they can be injected into humans and they can neutralize the virus. So finally, I would like to emphasize that since we do not have a vaccine yet, we do not have a treatment that is more than 1/3 effective, and that we as a human population are naive to the virus, we're not educated against it, our immune systems do not have memory, really the best advice is that an ounce of prevention is worth a pound of cure. And I know Dr. Styn went over many of the preventative common sense measures that can and should be taken. With that, I'd like to thank you for listening, and I would like to introduce the next speaker, my colleague and the clinical director of the Starzl Transplantation Institute, Dr. Abhinav Humar, who will talk about running a transplant program during a pandemic.
All right, thank you very much, Fadi. That was an excellent presentation. So I don't have any slides because really what my plan is to really talk about, tell you a story about COVID and transplant, and specifically our transplant program and how we've managed and what's happened to it during these times, and try to look as to what perhaps the future might hold and how this is going to change our landscape. So let's rewind back to probably sometime in early March, and I think at that point it was just becoming quite apparent that this was a major problem that was going to be affecting the United States, and programs all across the country were being essentially curtailed, shut down. Surgical programs I'm talking about, and specifically transplant programs. And there were many reasons for this. There were many areas of the country that were seeing a lot of cases, and hospitals that were being inundated with cases, specifically New York, Seattle, and some of those places. And they really had no capacity to be able to handle other non-COVID type of patients, including transplant patients. And specifically with transplant, there was concern, as you've already heard, the risk of transplant patients, because they're immunocompromised, of getting infection and being at higher risk for infection, and the course that this would take. And as a result of this, many programs across the country at that time essentially shut down transplant operations, and it was variable across the different programs as to what we saw. Some programs stopped doing all transplants completely. Other programs stopped doing more elective type of transplants, such as kidney transplants, and some programs stopped doing live donor transplants, depending on where they were. But many programs stopped, and patients were not able to have access, or their surgeries that were already scheduled were canceled. And if you look at the national data on transplant during this period of time, March and April and forward, you saw a significant drop in the number of transplants across the country, both in the number of live donor transplants, which were more elective and scheduled, but also of deceased donor transplants across the country. The number of suitable organ donors had dropped significantly. The number of donors that people were willing to utilize had dropped significantly, because there was the concern that they may be transmitters of infection, that we didn't know if the donors may potentially harbor infection and be asymptomatic from it, and then subsequently transmit it to the recipient once they had it. And obviously, in an immunocompromised recipient, the worry was that this would be essentially a virus that would go unchecked. And so many programs, as I said, across the country slowed down their operations, and transplant as a whole saw a drastic decrease in the number of transplants done. Our story is a little bit different, in fact, quite different from this, and we persisted with our transplant program and continued to do transplants during this period of time. And if you look at our numbers had not really changed. All of our transplants, whether they were kidney transplants, liver transplants, live donor transplants, or deceased donor transplants, we really did not cancel any of our cases. And in fact, I was just looking at our numbers for transplants done up until the first 6 months of this year. And we've done 90 liver transplants, 108 kidney transplants to date in this half year, which is more than we've done certainly in the last few years at this period of time. And so we've been actually busier than ever during this period of time. And in fact, if you look at some of our programs, in April, the month of April, we did 15 live donor liver transplants, which is the most that we've done ever in the history of UPMC in a single month. So it was our busiest month ever at the Starzl Transplant Institute for that specific transplant. And in fact, our second busiest month ever for live donor liver transplant was March, the month before that. And so we kept doing those. And so what was our method of thinking, and why were we so different than from other centers? Did we just ignore all of this and ignore the advice and just decided to plow ahead? And of course not. We had a strategy in place and had a different philosophy, so to speak, of thinking about this. And our philosophy was really based, one, on more risk and benefit, that transplant patients are at risk, and are at risk with a transplant and are at risk without a transplant. And what do I mean by at risk without a transplant? Well, liver transplant patients have a potential waitlist mortality and that a risk that their liver disease can get worse while they're on the waiting list, that their cancer can potentially disseminate during that period of time if that's what they're being transplanted for. But even kidney transplant patients have a significant mortality risk associated with being on dialysis for any period of time. On top of that, you have to couple that they also have a risk of developing COVID infection during this period of time. And it's very difficult, for example, for someone who's on dialysis 3 times a week to socially distance themselves because they have to travel to their dialysis program. They may have to use public transport during that period of time. They have to be in a dialysis center where they're exposed to other patients. And so they're exposed nonetheless, probably even more so than a person who doesn't have chronic illness. And the chronic illness is what really is the problem. And we know based on data, both from international as well as our own local settings, that patients with chronic disease, especially chronic liver failure or chronic renal failure, especially those that are dialysis dependent, if they do get an infection, if they get COVID infection, their mortality risk is in fact very high. In fact, as high as if they had a transplant or maybe higher. And so they're not really you're not really offsetting the risk by postponing their transplant. And so we felt that it was best to proceed with transplant because of the risk that they had. And in fact, this was verified by CMS, who then published subsequent to this, published guidelines as to what cases, surgical cases, were considered as elective and what were not. And transplant was put in the list of cases that were not considered to be elective cases, even if it was elective, meaning timed, such as a live donor kidney transplant or a live donor liver transplant. That still was not, in the true sense of the word, an elective case that could afford to wait. And so we moved forward with transplants and continued to do this. But again, we did this in a very thoughtful manner, and we're able to do it because of several things. And one of the main things was that we were fortunate in that our local area was a low COVID area, that we had not as many cases, certainly as very high risk areas such as New York at that time. We saw very few cases. And so the risk of infection was low to begin with. And very early, UPMC had realized that this was an issue and had implemented measures in place to ensure the safety of the patients as well as the health staff that were looking after these patients, which included things such as screening of every single person that walked into the hospital. Every single person had their temperature checked. Every single person was required to wear a mask, regardless of whether they were a physician, whether they were a non-healthcare worker that were working in the hospital, whether they were a patient, or whether they were someone visiting the patient. Everyone in the hospital was required mandatory to wear a mask, have their temperature checked, and go through a screener before they were allowed to enter into the hospital. The other thing that really had an impact for us was that we were able to, thanks to the foresight of UPMC and the resources available to us, we had access to testing of our patients at a very early stage and widespread testing. And so we were able to test all of our patients well ahead of the surge in testing that occurred throughout the country. And so when we started doing, and as we continued to do transplants, we ensured the safety of both of our donors as well as our recipients by testing everyone prior to the transplant, regardless of whether they had symptoms or not. And now this is standard across the country, but at that time, when we first started doing this, it was not, because the amount of testing was not available widespread. And yet we tested every single patient 1 to 2 days prior to the procedure to ensure that they were negative. We tested every single deceased donor that we were accepting to ensure that that they were indeed negative. And this helped us to minimize the exposure that we were giving to our patients. That, in combination with utilizing all of the standard procedures such as wearing of protective equipment and the social distancing guidelines applied inside the hospital, and all of that were taken to minimize the risk to our patients. We tried to get our patients out of hospital as soon as possible, and then subsequently ensured that their safety was there by having them follow a strict regimen of isolation, ensuring that they were not in contact with multiple people, and going through with them the guidelines of how to minimize this. And also the other thing that helped us was we adopted telemedicine and had this capability actually at a very early stage, well before this infection came into play, because we had plans for telemedicine well ahead of time. And so we were able to transition many of our patients, including those patients that were well out from transplant, that didn't need to be seen on a face-to-face basis to follow their care, to a telemedicine type of thing. And for a period of time, much of our post-op care, especially late post-transplant care, was done through telemedicine. So at the present time, we are pretty much, I would say, back to full operations. As I said, we never really slowed down. Transplants are being performed. We offer transplants to all of our patients. In fact, have offered transplants to patients from all around the country, especially in places that have been worse hit by COVID, and that have had their access to transplant taken away because their transplant programs have been shut down. And so we've seen patients that have come from Florida, from New York, and various other places, and have done transplants on them because they did not have access to it in their own city. Going forward, we feel we have a very safe and effective mechanism in place so that we can continue to offer life-saving transplants to all of our patients. We continue to follow extensive screening and monitoring and testing of patients before the transplant, during the transplant, and after the transplant. We follow full protection for all of them, and ensure that our patients are following the guidelines for social distancing, and teaching them really how to stay safe during this period of time, because we recognize that they are at higher risk, and that they are at higher risk of problems if they do get infection, but realizing that this is offset by the benefit that they're going to gain by having a functioning organ. And lastly, we have in place flexibility, because we realize that we're still just in the midst of all of this. We don't know what's going to happen going forward. We've seen a resurgence of cases, as many places have across the country. And so we've had a plan in place to what we do as we see more cases in the hospital, as what we may have to do, so that we ensure the protection of our patients and ensure that they're getting transplants in a safe fashion. So I'll stop there, and I think that'll give us plenty of time for questions.
Thank you so much, Dr. Humar. The first question is for you. Do transplant patients need to follow social distancing guidelines above and beyond what is recommended?
Well, they certainly need to follow the social distancing guidelines, and we emphasize this to all of our patients, that they really need to be very fastidious about this. In fact, early post-transplant, the best strategy is for them to try to limit how much exposure they're having to other people, and so they're best to essentially stay at home and limit how much time that they're spending outside of the home. And certainly, if they're outside of the home, they should be wearing masks at all times, and very good hand washing and sanitizing. So yes, they need to follow the social distancing guidelines to the letter, really, and even more so in some aspects.
So to that point then, is it safe for transplant patients to travel at this time?
So we've generally advised transplant patients to limit and avoid travel if at all possible. Now, sometimes they do need to travel, especially if they're living farther away and come to the transplant program to see us. But beyond that, we ask them to really limit and avoid all other travel. So certainly travel for personal reasons, vacation, and those type of things at the present time, I don't think is a very good idea for most transplant patients, especially those that are early post-transplant. And there are very many places across the country that are seeing quite a surge in cases. And so our advice to our patients is, if at all possible, they should stay put.
Okay, great. Thank you. The next question is for Dr. Lakkis. Can COVID infection cause rejection or damage to a transplanted organ?
Yes, that's a very important question. So I'll start with the good news. I had a conversation with one of my colleagues in New York who had many transplant patients hospitalized for COVID infection. And the number was actually 120, many of them high risk. And the good news is that only one patient out of 120 had rejection after COVID infection. And the main reason was that they had to reduce the immunosuppression by a large degree. So in general, the COVID infection doesn't seem to be increasing the rate of rejection, even in patients whose immunosuppression has been reduced. However, as I mentioned during my lecture, if someone is in the intensive care unit, they have a severe pneumonia, their oxygen is low, or their blood pressure has dropped, a transplanted organ such as the kidney or the liver of the heart or the heart can be damaged. But that's really more a consequence of being very ill rather than the infection directly affecting the transplant organ or causing rejection.
If a vaccine for COVID becomes available, would it be safe for a transplant recipient to take it?
So the answer, the general answer is yes, unless it's a live attenuated vaccine. So a weakened virus, even though it doesn't cause illness in a healthy person, it can spread in an immunocompromised transplant recipient. So in general, transplant recipients are told not to take a live attenuated vaccine, but any other type of vaccine should be safe. Of course, if it's already been vetted and tested in the general population. And the other important point to make is that the vaccine can be administered prior to transplantation in a new recipient and also can be given to someone who's already had a transplant. Again, the quick answer is yes, it is safe unless it's a live or a living virus, although it has been weakened.
Great, thank you. The next questions are for Dr. Styn. Does more testing lead to more cases?
And so this has been something that has been questioned in the news a lot. And I think, again, it's creating a lot of confusion because the cases will be there whether we identify them or not. The testing helps us to identify cases. So obviously, if you're not doing any testing, you're not going to identify any cases. And the more testing you do, the more cases you will find up to a certain extent. And so we want to look at the proportion of positive cases to the proportion of positive tests to the proportion of negative tests when we're trying to evaluate whether we're seeing a true increase or whether we're seeing an increase that's simply due to the number of tests. And in a lot of cases where we've seen an increased number of cases, that proportion of positive tests to negative tests has either stayed the same or we've still seen a lot of positive tests. You would expect to find a lot more negatives, and you'd expect to get down to about 9 negatives for every 1 positive when you're doing adequate testing is one measure that I've seen. So no, the short answer is no. More testing is not going to create more cases. To a certain extent, it will identify more cases, and that's definitely what we want. We want to identify as many cases as we can.
Thank you. And our last question, what is the point of closing bars?
And this has been a source of frustration here in Pittsburgh and in other places that bars seem to have been selectively outlawed, so to speak. And it's really, if we think about the behavior and we think about the prevention strategies that we want people to assume, that's nearly impossible to do in a bar, right? We want people to stay 6 feet apart. We want them to wear a mask. You can't really wear a mask when you're drinking. It's no fun to hang out with your friends when you're 6 feet apart. And of course, as you drink more, you start to lose inhibitions a little more. And so you may end up being closer in contact. You hang out a little bit longer. So one kind of guideline that we follow here at Pitt is to try to limit your close contact with people to less than 15 minutes. And so bars just really are a perfect atmosphere to not follow the public health guidelines. And that's really why bars have been one of the businesses that have been targeted as we see these increases in cases.
Thank you so much. And with that, we'd like to bring back Sandy Chico for some closing remarks.
Thank you to Dr. Mindi Styn, Dr. Fadi Lakkis, and Dr. Abhinav Humar from the Thomas E. Starzl Transplantation Institute for joining us this afternoon and sharing their perspectives on COVID-19 and transplant. As you've heard, our work has not stopped, and we proudly continue to serve our patients. If you have any questions about anything you've heard today or want more information about the exciting programs happening at the Starzl Transplant Institute, I encourage you to reach out and we would be happy to assist you. Thank you for joining us today, and stay tuned for additional virtual classroom presentations in the coming months.